Hello, everyone. My name is Donnelly Moulton, and I'm going to be your moderator for this afternoon's session. I'd like to welcome everybody. We'd like to start with an official acknowledgement that we are in Mi'kmaq territory, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the treaties of peace and friendship with Mi'kmaq and Maliseet people, first signed with the British Crown in 1725. The treaties, however, did not deal with surrender of lands and resources, but in fact recognized Mi'kmaq and Maliseet title and established the rules for what was to be an ongoing relationship between nations. And it is in that spirit with which we are here today to talk about bladder issues. And we've had tremendous interest in this topic. Participants are still starting to flow in, and we welcome you. More than 400 have registered to hear from Sheila and Sarah, and I do believe that is a record for us. So it speaks to the importance of the issue, and it also speaks to the interest in the issue. And so SCANS is delighted to be furthering the conversation. So let me introduce our speakers. We have Shelah Meagher, and Sheila, there we go, that one's Sheila. And Sheila is the owner of SheSpot Halifax, which is a Nova Scotia-based incontinence clinic. And Sheila loves this title. Many of us would not, but Sheila loves what her clients call her, which is the Pee Queen. And she has that title because she loves to talk about this issue. And when you hear her speak, you will understand the importance of the issue that she is speaking about as well. She is a certified Emsella practitioner, and she has a background in science, health technology, and research. So welcome, Sheila. And Sheila and Dr. Sarah Tanner are going to jointly be presenting. Dr. Tanner is a member of both the Nova Scotia and the Canadian Associations of Naturopathic Doctors, and she has owned Natural Choices Healthcare in Halifax since 2006. She graduated from the Canadian College of Naturopathic Medicine in Toronto. We will not hold that against her. She holds a Bachelor of Science from Dalhousie University, and she teaches research methods at the Canadian College of Massage and Hydrotherapy. And she and Sheila work together frequently to treat the underlying causes of bladder issues. And that's one of the themes I think you'll find this afternoon is the holistic look at the issue that our two speakers want to provide. And so at this point, I will officially turn it over to Sheila to get us underway.
Thank you very much, Donnelly, and thank you to all of you for being here today. Sarah and I have been blown away by the response to this presentation, but I guess I shouldn't really be surprised because the latest research from the States, which was with 5,000 women 20 years plus, showed that 62% of them have some kind of bladder issue. And that's just the women. So clearly this is something that we need to be talking more about. Now, today, we're just going to have an overview. This is not like a deep dive medical treatise on all the things that can go wrong with our systems. What we're trying to do is give you enough knowledge so that you can understand a bit better what might be going on in your own body and find the path that's going to work best for you for doing something about it. So it's just an overview of how the system is supposed to work and how it can go wrong and what you can do about it. So to begin, I'd like to just review what is a well-functioning system, because people aren't always sure. So first of all, my single prop, we're supposed to pee this much. This is a 2-cup measure, so 500 mils, and between 500 and 700 mils is a normal healthy void. That's a lot of pee. If you are, you're supposed to pee this amount about every 3 to 5 hours, depending on how well hydrated you are, whether it's boiling hot out, whether you're exercising or whatever, but in that vicinity. If you just pee in this little amount every hour, then your system is not functioning properly. Now, in between these lovely big voids, we're not supposed to leak when we sneeze or cough or exercise or jump up and down. We're not supposed to leak when we're on our way to the toilet. We're supposed to be able to get to the toilet in a calm fashion as opposed to trying desperately to hold on. And at night, you should be able to sleep through the whole night, or maybe get up once to go to the toilet, because our bodies actually have a mechanism for producing less urine during the night. That's if everything is working properly. So let's take a look now at what's behind having it work properly and what's behind it falling apart. So could I have the slides now? There we go. Okay. So we take a whole body approach to this problem, because it's very rarely about one thing, just the bladder or just the pelvic floor. And so we've found if we bring to bear every part of the body, we get much better results that last longer. So we look at this in terms of biomechanics, neuromuscular control, and the body's ecosystem. Okay. That is not going forward. Technical glitch. Now, boom. Here we go. Biomechanics. What do we mean by that? So that is essentially, is everything capable of functioning the way it should? So the pelvic floor is supposed to hold the sphincter shut and keep the pee in, and then it's supposed to be able to relax when we want to void in order to let the pee out. And the bladder is supposed to be able, in a relaxed fashion, to fill up with pee, and then it's supposed to be able to contract and hold that contraction long enough to void completely. The urethra has its own pressure, and the sphincter needs to be able to open and close. It goes through the pelvic floor, but it has its own opening and closing, which is aided by the pelvic floor. And is everything in its right place? So those are the basic functioning components, and are they capable of functioning? And then the next level is neuromuscular control, because you could have a pelvic floor that's capable of functioning, but if your brain isn't in charge, and if your brain isn't in charge of the bladder, then those things are not doing you any good. So this is a really crucial part of the mix, is that neuromuscular control. And then we look at the body ecosystem, and this is particularly where Sarah comes into the play. And there's two aspects to this. First of all, is what's contributing to malfunction? So are there other things at work in terms of underlying medical conditions, chronic inflammation, chronic stress, chronic oh my goodness, chronic various things that may be contributing to the problem. And then the second part of it is, how capable is your body of nourishing at a cellular level those systems, the biomechanical and the neuromuscular control systems, so that they can heal if you're trying to remedy things, or be vital if you're trying to maintain things. So if your body is lacking the basic building blocks for cellular health, then anything that you do to try and treat your problem is going to always be butting up against this limitation of your body to feed those systems at a cellular level so that they maintain vitality. Okay, so this is a very simple look at how it's all supposed to work. So down on the left there, you can see the bladder. It's governed by the detrusor muscle. It's important to know that the detrusor muscle, which expands when it's relaxed and is the thing that contracts your bladder to pee, is a smooth muscle, which means it's like your lungs. So you have some capacity, you have some control over what it does, but it also is capable of working of its own volition if it thinks your body is in jeopardy. And this is an important part of the mix. Now, in a well-functioning system, the bladder, as it starts to fill, sends signals up to the brain, up to that pons area of the brain there. And it starts to send these signals when it's only about a third full, and then it will send another one. And then when it's really full, it's going to send a more urgent signal to the brain. As it sends those signals, the brain is then supposed to respond by saying initially, okay, noted, you just keep up the good work. And the brain keeps the sphincter closed, and it keeps the pelvic floor tightly holding that, not like over tight, but holding that pee in. And then when it's time to void, the brain sends another signal back to the bladder saying, okay, you may now contract, and it sends a signal simultaneously to the pelvic floor saying, you may now relax. And those two things work in harmony with one another, so that when the pelvic floor is, when the bladder is expanding, the pelvic floor keeps the pee in, and when the bladder squishes, the pelvic floor releases the pee. That's how it's supposed to work. Now, two of the main problems with bladders are urgency incontinence and stress incontinence. There are other peripheral problems, but these are the two that we're going to deal with today because they're kind of the major ones. So on the left, you see the normal bladder. In the middle is a depiction of urgency incontinence. It's a little bit misleading because that bladder looks like it's full, but you can have urgency even when there's just a little bit of pee in there. The essential thing about urgency incontinence is it's kind of an inside out issue. So the bladder thinks that it needs to void even when it's not full. Stress incontinence, on the other hand, which is the one on the right-hand side, is an outside in issue, which is that there is extra pressure exerted on the bladder, and it squishes the balloon basically, and the sphincter and the pelvic floor cannot withstand that pressure. So that's a very simplistic way of looking at these issues, and we're going to get into more on both of them in a sec. It's important to understand that these problems are typically a one-way trajectory. So when you start to get issues, they're inevitably going to get worse unless you take care of them in one manner or another. Just like any other deterioration of a body system, it's way easier to fix it the earlier you catch it rather than waiting till it's a colossal mess. It's still possible, but it's a lot more challenging to affect a change. So let's unpack stress incontinence a little bit here. So that is basically a pressure issue. So your bladder is filling up in the intra-abdominal cavity, and it's enjoying a kind of even pressure. And then when something happens, like our diaphragm comes whooping down on it when we cough or sneeze, or we go to lift a heavy object and our abdomen comes squishing in this way, or we're jumping up and down and gravitational pull is sucking that pee out of there. The pelvic floor and the sphincter, the urethra is going through there. The pelvic floor is supposed to keep that sphincter closed against that increased pressure. And when the sphincter and the pelvic floor are not up to the task, then that increased pressure is simply going to force pee right out of the system. Now, the difference between stress and urge is that you don't feel like you're peeing. You don't have that peeing sensation. You're just jumping up and down or even walking along, and pee is simply leaking out. And you don't know it until you realize that you have wet underwear or a wet pad. Now, why does this happen? Well, there are several reasons, but one of the most common is laxity in the pelvic floor and sphincter, or damage in those two areas. So the pelvic floor is like a hammock that holds everything up. And as it deteriorates, just like any other muscle, when it gets flabby, then it's a saggy hammock, and all the organs are now out of place, which exacerbates the problem. That's called prolapse, when everything's kind of lying on its side. Now, quite apart from prolapse, if that muscle is not strong enough to keep the sphincter closed, then the pee is going to come out. Likewise, if you've sustained damage through surgery, childbirth, prostatectomies, for instance, you may have a damaged pelvic floor, scar tissue in your sphincter, which is preventing that nice tight closure that you need to keep the pee inside. This problem is often exacerbated by excess weight, and I'm not talking about 10 or 20 pounds, I'm talking about morbid obesity, in which case the sheer weight and the pressure of the fatty deposits all around the organs are going to contribute to the problem. If you have things like chronic coughing and constipation, that's a kind of constant wear and tear on your pelvic floor, which is going to further limit its ability to respond when you need it. And then, of course, there are also underlying medical conditions that can come into play, things like diabetes with its resulting neuropathy, and multiple sclerosis, which creates lesions on the nerves. Those things can interfere with the appropriate signaling between the brain and the pelvic floor to keep it closed when it needs to. Now, it's also possible to have this problem with resulting from the opposite situation in your pelvic floor, which is hypertension. So there are a number of ways that this can happen: chronic stress, and through overwork, too much ab work, or weightlifting. And what happens is the muscle then gets like this. It's way too tight and it can't relax properly, and nor can it tighten the way it needs to actually keep the sphincter closed. Now, I'm showing you this diagram here because it's interconnectivity of everything in our body is super important to this problem. It's not just a question of you've overexercised your pelvic floor, but those blue lines are the fascia that connect all the muscle groups within the body. They go from your toes up to your ears in the front and in the back. And if you have tension, for instance, in your jaw, your neck, your shoulders, that's going to translate right down into your pelvic floor. And when it does, it's going to limit the ability of your pelvic floor to do its job. So hypertension, it seems ironic, but a pelvic floor that's locked too tight is not going to do its job the same way as one that is too lax. Now we're going to get into urgency. So first of all, what is urge incontinence? It's when you really desperately have to pee, even when your bladder isn't full. It may be with or without accident, so it is possible to have a desperate sense of urgency, even though you never actually have an accident. And then in many cases, you have that desperate sense of urgency, which can also be coupled with an accident. So that's called wet incontinence versus dry incontinence. Regardless, the sense of panic is the same. It's usually a result of consistent triggers. So for a lot of people, it's the key in the lock, driving in the driveway, coming in from the cold, putting your hands in warm water, turning on the shower. There's a number of things that are incredibly common across a whole lot of people with this problem. Nocturia, which is getting up too often in the night, that is kind of related to urge. So you think you have to pee, even though you could actually go right back to sleep and not bother with that. And then OAB, that's overactive bladder, is really a result of giving into urge frequently over possibly decades. So now your system is convinced it has to pee every hour. So why does this happen? I'm going to turn it over to Sarah in just a sec, but I just want to put in the context here that your bladder is a voiding organ. So its job is to take stuff that's been in your body that's not supposed to be in your body and get it out of there. And because it is a smooth muscle, as we talked about before, and can act of its own volition, when it thinks that it's got stuff in there that needs to go out the door, it's going to do everything in its power to make that happen. But sometimes it gets a little overzealous. And Sarah's going to take us through some of the reasons why that can happen.
Absolutely. Thank you, Sheila. Hi, everybody. It's great to be here today. My job is to try to dissect the reasons, some of the reasons why the bladder pieces are happening. Unfortunately, it's never just one reason. Oftentimes, there's many reasons that are happening. So a naturopathic doctor can play that role, other health practitioners as well, in figuring out why things are happening the way they are. So what we've done today is picked out some bits and pieces of things that we see more often. So in terms of the bladder inflammation, inflammation, there is a condition called interstitial cystitis, which is an inflammation of the mucosal lining of the bladder. A lot of what Sheila has already talked about are symptoms of interstitial cystitis. So that's absolutely something that can be addressed. However, you can have regular bladder inflammation as well. That bladder inflammation, if that mucosal lining is inflamed, you're more likely to need to void more often because the urine in the bladder just creates that need to go. In terms of food, so if you Google what foods affect the bladder, you're going to find a lot of stimulants on that list. You'll find alcohol, caffeine, carbonation, chocolate, sometimes increased carbs will be on that list. Carbs are not your enemy for sure. But sometimes stimulant foods will definitely make you go pee more. And what I also look for is food sensitivities and intolerances in my patient base. And so what that means is if there is a food that you are sensitive to, not the general population with the stimulant, but you are sensitive to, that can make you have to pee more. So gluten can be a big one. I see a lot of people with potato intolerances who are having trouble with their bladder, but there are so many others as well. So that's definitely something you can investigate if you find that, if you feel like food is making your condition worse. Low-grade infections. So oftentimes your medical doctor will do a urinalysis and you can get a mild, moderate, or severe reading in terms of an infection or white blood cell count. And the mild infections, typically, we don't really think very much about them because they're not giving you symptoms of a urinary tract infection, but that can be a reason for inflammation in your body. The other thing that happens is this happens more often during perimenopause and into menopause as well. And once you're through menopause, it's still happening. So oftentimes you can deal with everything else, but if that low-grade infection is there, it does need to be treated. Sometimes that is an antibiotic that is prescribed by your medical doctor. Sometimes that's herbs. There's many different ways you can look at that, but it's identifying that it's there to begin with. In terms of the underlying medical conditions, Sheila started to address that. Definitely, if somebody has diabetes, their nerves are not as sensitive. You develop peripheral neuropathy. That includes the bladder as well. So we talk about nerves in the hands and feet, potentially legs, but also the signals are different. I'll get to thyroid in a little while. Sheila mentioned MS as well, but there are so many smaller things that when I get to the next part of my piece of the presentation, I'll get into just a little bit more. And then Sheila, I'll send it back to you about the faulty brain bladder signals.
Okay, so this is a thing about urge incontinence. So assuming that everything's a-okay with your bladder and you don't have those underlying conditions, but you might still have this sense of urgency, which increases over time. Oops. What happened? There's what I want. Well, there's where I want to be. So what is the mechanism behind that? Well, when your bladder sends signal to your brain is supposed to remain in parasympathetic and calmly tell your bladder to wait until you're on the toilet. But what can happen is that when your bladder sends that signal to the brain, sometimes even the very first signal, when there's just a little bit of pee in there, the brain goes into panic mode. And instead of going, yeah, it's okay, let's get to the toilet, now it goes, oh my God, we have to pee. And the panic is a result of the threat of an accident. Now, whether you have accidents regularly, which of course will make that threat feel worse, or whether it's accidents that you had back when you were a child and your body is remembering it, it is in effect a kind of small t trauma body response to the signal from your bladder of risk, the risk of an accident. When your brain feels that you are at risk, it switches from parasympathetic, which is where you have executive control, into sympathetic or the limbic system, and that's the fight or flight response. And so now you've gone from being in calm control of your voiding situation to your brain and your bladder basically having a little hysterical fit. And when you're in there, executive function kind of quietly leaves the room. So it is really vital to regaining control in urgency situations to stop that signal, which is very different from the idea that you could like stop your pee by holding on tightly. That really screws up your system. What we try to do is, if you know what your triggers are before they even happen, you distract the brain. So if putting the key in the lock is your thing, before you even get your keys out of your purse, you need to be thinking in terms of, okay, this thing is about to happen. We're not going to let it happen. We actually have control. You can count backwards from 10. You can spell a difficult word. You can do some deep breathing. There are a number of techniques. What we're trying to do is distract the brain, basically, so it forgets about that signal from the bladder for a moment. And whether that buys you 5 seconds or an hour, the objective is to get to the toilet calmly. So that is part of the retraining process. It is entirely possible thanks to the plasticity of our brains, but it doesn't happen overnight. So now back to Sarah. She's going to go in a little more detail about the body ecosystem that we were talking about before.
Perfect. Thank you. I apologize, everyone, for my 10-second exit from the screen. I had forgotten to plug my computer in and I didn't want to lose you all. So I did that and we're good to go again. I'll preface this slide by saying I'm giving a brief overview. If there are specific questions or things you would like me to go deeper into detail on, I'm very happy to do that. You're going to put your questions in the Q&A. And so I'm happy to do that. I'm picking out some of the bigger stuff, but there's absolutely other things. I see something else that I'd like to talk about too. So please don't hesitate to ask us to elaborate a little bit more as well. We want to give you the information that you're looking for today. Okay, thyroid. So your thyroid sits right here. It is the master gland of the body. It makes everything work the way it is supposed to work. The thyroid can become hyperthyroid or hypothyroid, and both types of thyroid concerns affect the bladder. When we're dealing with hypothyroid, we get the bladder doesn't work as well. We retain more urine. It affects our kidneys more. In hyperthyroid, we get more urgency. We get more incontinence. You're getting up more to pee at night. You're not emptying as well as you should. Sometimes that interstitial cystitis kicks up. So a lot of questions that I often get are, but I'm on Synthroid. My thyroid is fine. Why is my bladder still not fine? So what happens is that Synthroid is a thyroid hormone. And so that it's T4 that your body is getting, but that T4 needs to be converted to T3. So your numbers might look great, but maybe your body isn't able to utilize the T4 that it's being given. So when that happens, then your bladder still doesn't resolve. So a lot of people will say, well, my numbers look really great and I don't know why my symptoms aren't resolving. And that's the exact reason. So there's other ways around helping to support the thyroid that don't interfere with the Synthroid. You can absolutely still be on Synthroid. I'm not suggesting a medication change, but that is why sometimes if you're on Synthroid, the bladder is still acting up. Sometimes it's not the right medication, and that's a conversation to have with your doctor. So there are those things. The adrenal glands. So for those who aren't aware, they're these little tiny glands. They sit on top of your kidneys. So there's a big proximity of adrenal glands to kidneys and to bladder. Your adrenal glands keep you going. So if a bear is chasing you, they're supposed to pump out adrenaline so you can run away. That's great. That's wonderful. But what happens when the stress is long? We're 2 years into a pandemic right now. We still have our regular lives as well. Our cortisol levels start to be stimulated more. And so the more cortisol we have, the more cortisol we have, the more stimulated our bladder can be. But on the other end, if the stress becomes too much, then the bladder, the adrenal glands start to become dysfunctioned. They can't function as well. You're finding brain fog. You're finding your energy is lacking. Maybe you are in the bathroom all of the time. Flight or fight is something that many of you may have heard of. And so you get that stress incontinence because it's that flight or fight that you're always needing to go. It then becomes a habit. The other thing that adrenal glands work really well with is they help us to keep our electrolyte balance going on. And your electrolytes include your sodium, your potassium, your chloride. And if those things are imbalanced, your bladder can be affected. So that is a huge deal. And I'm seeing more and more adrenal glands becoming affected in the last 2 years than I ever have before. So that's typically something to think about. Prostate. So with the prostate, what ends up happening is that we often get an enlarged prostate. So I'm not talking about prostate cancer here. I'm talking more about an enlarged prostate. The other thing that the prostate needs to function properly are things like zinc, selenium, vitamin Bs, vitamin D often. And if those things aren't there, then the prostate cannot function the way it needs to. And as we age, the prostate needs more of those minerals going on and sometimes those vitamins. Obviously, I don't recommend going out and just picking up a whole bunch of vitamins. I recommend consulting with somebody, but keep that in mind. It's not, if your prostate is inflamed, that's not it. There are options around that. There are other herbs that can be supportive of the prostate as well. And the prostate absolutely can contribute to the bladder. In terms of the hormones or lack thereof absolutely can affect the bladder. In so many different ways. So all the adrenal glands are hormones, the thyroid deals with hormones as well. And then we've got the too much or lack thereof of estrogen, progesterone, testosterone. So all of those pieces absolutely affect the bladder too. So if those are out of balance for you, the bladder can become affected. Even if the friend beside you has imbalanced hormones and they don't have any bladder issues. Everybody reacts to things differently. And that's one of the reasons why I love my job, because I'm able to help people figure out what they're reacting to and what's happening. Now, Sheila, I think I have one more slide, correct? I think. Yes, there we go. Okay. So, in terms of diet and lifestyle, how else can a naturopathic doctor or somebody else, with similar training help support you? So blood sugar balancing, you don't want that peripheral neuropathy. You want your bladder and your nerves to be functioning as well as it can. So the blood sugar balancing is really important. You can look at that as getting more protein. You can look at that as eating regular meals. You can look at that. Sometimes people will think about intermittent fasting, and all of those things are talks on their own, but it's absolutely something that can be addressed. Even if you have been diagnosed with diabetes type 2, that you can still support that side of your system. The deficiency part is my absolute favorite part to look at. So a couple things. Number one, B12. In North America, we have a very broad range for B12, but B12 helps nerves, muscles, mood, energy, immune system, digestion, you name it. Pretty much everything is supported by B12. And in Halifax, our range is 138 to 672. It's a huge range. If you're down in the 100 range, you are at risk of nerve damage, and that's scary. But if you're below 550, you are at the risk of everything just not working as well as it should be working. And so if you haven't already, I recommend talking with your doctor, getting your B12 checked, or if you already get B12 shots, making sure you're above that 550 mark. B12 and bladder go like this, is what Sheila and I are definitely learning as we go through this together. Vitamin D is very similar. Anything under 75 is considered low, but you want to be at least at 120. And vitamin D basically helps every organ system in your entire body. That's another whole thing too, but you want to optimize all of these levels. Magnesium. There are many types of magnesium. If somebody has constipation along with their bladder issues, a magnesium citrate works really well. If somebody's still getting hot flashes and no constipation, a magnesium glycinate works really well. So every single person needs a different type of magnesium, but magnesium makes your muscles work. It also supports your nervous system. So it can help you with sleep, it can help with anxiety, but it helps with that sphincter and the bladder muscle working. So the magnesium is very important. We're often finding with Emsella treatments that people are in need of extra magnesium before and during and after their treatments, because then the muscles respond better. So think about magnesium if you're finding that you're sore a lot, somebody with fibromyalgia, but even just a regular person, it's very difficult to get enough magnesium. Toxins. So I talked a little bit about toxins in terms of food intolerances, but like Sheila said, the bladder is something that flushes everything out. So that's one of our ways of getting rid of stuff. So if we have a lot of toxins in the body, the bladder's trying to get rid of them. If your liver isn't functioning as well as it should, then your toxin clearance goes through the bladder. I'm not a huge fan of major liver detoxes, but I do like to make sure we're kind of addressing toxins, whether it be food related, pesticides, different environmental things, mold, dust, all of those kinds of things are worth thinking about. Workplace exposures. So think about all of that and your toxin load. Microbiomes. So microbiomes are a hot topic right now. They are what a lot of people understand, that there's a gut microbiome. 80% of your immune system lives in that gut microbiome. That is very, very, very important to support. What a lot of people don't realize is that there are other sets of microbiomes. So there's one in the kidney and the bladder, orally, on your skin, intranasally, so in your nose, and in your vagina as well. So there are microbiomes everywhere in your system. So if the microbiomes are not balanced, if the mucosal lining in those barriers or in those linings are not, there are holes, we call it leaky gut or a leaky mucosal lining, the filtration system doesn't work very well. You get more kidney stones. You have so many things. There's some research out there that is showing that urge incontinence is related to an imbalanced microbiome. So we are getting there, it's coming, but the knowledge we don't always know enough yet. But there are enough bits and pieces that we can usually piece things together so that people do get better results and feel better. All right, Sheila, I could go forever, but I think I'll send it back over to you.
Well, there may be more to go over when we start answering questions as well. Okay, so that covers some of the systemic issues and things that we can do to help ourselves with these situations. But what else can be done about bladder issues? So there are biomechanical improvements, and then there are neuromuscular control improvements, since both of those things need to work together to get total control. I'm going to go through a few of the more common treatment options right now. Now, this first slide is not actually my initial recommendation. This is kind of like the last recourse if other more moderate options have not been working for you. But for the sake of completeness, I put this in here. So on the left, you see surgery, male or female. What may or may not be easy to see are these little slings. This is one form of surgery. And the little slings can hold your bladder in place in case of a prolapse. They can give your urethra extra support. So it gives it a little more tensile strength to hold pee in for men or for women. In the upper section there is an illustration of Botox. So this is a relatively recent thing that a urologist has to do. And they're basically putting Botox inside your bladder. This is for spasmodic bladder. So one that's become incredibly overzealous and is just basically squishing to get pee out way too often of its own volition. And Botox can basically chillax your bladder the same as it does with other Botox applications. Then there is the drug route, so mirabegrin, sulfonylurea, oxybutynin. These are all typical pharmaceuticals that are used again to treat the symptom of spasmodic bladder. They do have a lot of side effects, and their effectiveness tends to wear off after a couple of years. But they can be like many pharmacological solutions, they can be a godsend to people who have really massive problems. On a less invasive note, we have pelvic floor physiotherapy, which is an excellent first stop in treatment. So what you may or may not know about a pelvic floor physio, it's not 100% non-invasive because they do feel around inside your body, vaginally or rectally. And the great advantage of this is that they can tell what's going on, and whether you are able to engage your pelvic floor, whether it's lopsided, is it stronger on one side than the other, is it really lax, is there scar tissue in there, how well can you actually engage it. They may use a device for measuring that. Is it actually locked tight? And then on the basis of what they find, which is super useful information, they will give you exercises to rectify that. And those exercises, of course, then are up to you. So you have to be able to do the exercises well enough and often enough to affect a change over the course of 3 to 9 months, depending on your situation. Along with that, there are these devices on the market that looks like a little vibrator, but it's not. It's actually to measure your ability to engage your pelvic floor in the exercises that you may have been given. And it works with a little app on your phone so that you can see the degree to which you are successfully engaging and for how long. Then there are other forms of exercise. Now, I'm a big fan of Pilates for incontinence issues, for all kinds of issues, actually, because if we think back to that picture of the fascia with the blue fascia coming down the body, if you just work on your pelvic floor and you aren't working on the other parts of your body that are attached to your pelvic floor and therefore might be putting it out of alignment, then you're always running into this limitation. So if your head is forward, if you're a little sway back, if your gait's wrong, if other parts of your body are out of alignment, then they are potentially always going to be throwing your pelvic floor out. And as you try to make your pelvic floor a perfect, evenly toned bowl, these other limitations are constantly working against those efforts. So if you include a Pilates, a yoga, maybe massage in the mix to try and get whole body alignment, your pelvic floor specific exercises are going to be working a whole lot better. Now I add this is not a treatment. This is a management tool for major risk situations, like you're going to do a workout at the gym, or you're going for a long hike, or you're going dancing or drinking and dancing, or other situations in which you're more likely to have stress leakage. So a pessary is something that gets fitted by the IWK Bladder Clinic, for instance, and they're different shapes and sizes, and they're meant to stay in for days on end. What it is a device that it goes in the vagina. Depending on its shape and size, it can actually hold your bladder up in position in the case of a prolapse. But the main function is to press against the urethra and cause a bit of constriction there, so that you have you can pee through that constriction, but you have a little extra guard against leakage. It's kind of like putting a storm door outside of the main door of the sphincter. Now, its cousins, the pessary's cousins, are things like Impressa, and that is a tampon with a hammer head, essentially, and it does the same thing. It provides pressure to the urethra, and you use it when you're in a risk situation, and then you throw it away after, like a tampon. Or there are products like Uresta. There are many other ones. I'm not like a big Uresta fan. I just happen to pull this one off of the internet. But you can see that little device in the bottom there. It's like a little plug. You put it in, and that protuberance on the sides presses against your urethra. A number of people swear by this for getting through their workouts and other risk situations. And then in the case of a Uresta kind of device, you just take it out and wash it and you reuse it. So for people who don't like to just throw things away, this kind of device is a good management tool. Now, speaking of management tools, for bladder retraining, which we talked about very briefly with respect to urgency, this is a bladder diary. And I think we have it in the resources section. Yes, I'm getting nods from the tech team here. So you should be able to download a version of this for yourself if you want to try it. What it involves is keeping a measure for a few days of everything that you had to drink. What is it and how much of it did you have? And then how much did you pee and when? And it's important to measure the amount of pee, because a lot of people will think, oh yeah, it's a full void. And then they discover they never pee more than 150 mils as opposed to 500 mils. And so it can be very illuminating. And also in there is, did you leak on the way? Did you leak with activity? And how great was your urgency? So through these bladder diaries, you find out a lot about what kinds of things really set you off, what tends to create more urgency for you. And you discover just what your voiding patterns are and how capable or not capable are you of increasing the interval between your voids. So we find out a whole lot just by keeping bladder diaries. And especially if you're in retraining, it does show you your progress on a day-by-day basis. So that's a really useful tool. We also use a lot of acupuncture at SheSpot in conjunction with Emsella, but acupuncture by itself, you don't have to come to SheSpot for it, is an excellent tool for urgency in particular and leakage to some extent. I'm not talking about the kind of acupuncture which is sticking needles in pain points, but rather the systemic Chinese traditional acupuncture, because it works on the nervous system. So obviously in urgency, where the nervous system is highly involved, it can calm those signals down. It can calm the whole body down. It can take the adrenal system back into a parasympathetic state. And it can strengthen your neuromuscular connection, which is one reason why we use it a lot as a conjunctive therapy. Oop, what happened? I had one more slide. It's coming back. That last slide. There we go. Okay. So this is our foundational therapy at SheSpot. So I sure didn't want to miss this one. Emsella is Health Canada approved to treat all forms of incontinence. And you sit in the chair, just like these models, fully closed, and it delivers high frequency electromagnetic energy up into your body, 10 centimeters in. So it creates a pelvic floor re-education. It's not just a question of toning. It also works for hypertense pelvic floors, because it goes through periods of contraction and relaxation. Your pelvic floor has to be able to do both things to function properly. But in addition, it creates, through that stimulation, neurogenesis and revascularization of the system. And so that super important neuromuscular control is reestablished. And this typically happens, the standard protocol is 6 sessions of 30 minutes each over a 3-week period. And you don't have to do anything, no exercise, no downtime, no nothing. So that's why we like it so well. We get very good results with it. And that's it for us. So now we're going to have a 10-minute break, and then we're going to get into questions. I'd like to point out that the question field is private. So you can ask anything you want, and nobody else knows that you've asked us. Asked it except for us. Donnelly is going to read those questions aloud, but without anybody's name involved. So you can just ask whatever you like, and it's going to be completely discreet.
Hi, everyone. Welcome back. Look, that was very, very helpful, Sheila and Sarah, and I can tell you exactly how helpful it was because when I appropriately left the break at the beginning for my pee break, I think we had 3 questions. I came back and we now have 34. I've also checked the chat tool as well, and there are questions in there. Although the hope is that you will use the Q&A tool at the bottom of your Zoom screen. And so what I'm going to try to do as moderator is get us through as many questions as we possibly can. If there is not time to answer all of the questions, we will see if there is potentially a way with Sheila and Sarah's help to answer the additional questions and perhaps send them to you and or post them on our website, where a recording of this session, of this presentation, will also be available. In some cases, as I'm going through the questions, there are very similar or duplicate questions, and so I will try to just reference those once to save us some time. Some of the questions are very broad in general, not surprisingly, and some are very specific. And our first set of questions tend to fall into that very specific category. They're following up on information that you've provided and looking for a little bit more specifics. So the first question is, how do you know if your T4 is being converted to T3?
Absolutely. So I think that's a me question. So this is actually quite challenging in Nova Scotia right now. So when you are getting blood work done, you want to look for a full thyroid panel. So that includes TSH, T4, T3, and sometimes thyroid antibodies. Unfortunately, what is happening right now, and I won't get into the politics behind all of it, but what's happening right now is that the labs in Nova Scotia are canceling T4 and T3, sometimes antibodies. This is not a COVID thing. This is something completely different from COVID, because I know there are certain tests like the hemoglobin A1C for blood sugar that is being canceled because of COVID, but T3 and T4 is being canceled. So sometimes it's more challenging than it used to be. So what we look at is if we have a T4 and a T3 level, we're looking at how much of that is being turned over into T3. So T4 can actually be quite low, but if your T3 levels are very good, that means you've got enough T4 to convert that over. For those of you in Halifax or surrounding, close enough areas to Halifax, seeing a naturopathic doctor in the area, we do have a private lab that we can send people to. I think getting a T4 level done is $20 and getting a T3 level done is $24. So a lot of people do choose to go that route, not all of the time, but sometimes just a single blood test can kind of give you an idea of where you stand. And then your naturopathic doctor will get those results and can review them with you. If there is a problem with your TSH, or if you had established thyroid disease, your medical doctor is able to order T3 and T4. So there are a few different ways to do that.
All right, thank you very much. A related, I think, very specific question regarding B12. You mentioned 550, and the question is what, grams?
Oh my goodness. I think it's nanograms per milliliter. So that's not what I'm talking. So when I say 550, I'm not talking about how much to take. I'm talking about what it should look like on your blood work. So within North America, 550 in our units. I do believe it's nanograms per milliliter, but that is a bit of a guess. That range actually comes from research and values used by Japan, Australia, many European countries. So like I said, North America uses that broad range, but other countries are going, how low is it before it really starts to affect us? And so that 550 mark is kind of what's been decided on.
Perfect. And again, I think related to this is, what's the normal range for magnesium?
Okay, so with magnesium, So when you do magnesium on blood work, that is telling you what's circulating in your blood, in your heart, in your brain, in your organs. So that's telling you that those specific organs that you need to keep you alive have enough magnesium and they're doing great. What it's not telling you is what's in your muscles, what's in your nerves, what's in your specific cells. So there really isn't, the magnesium range is so tiny. So I think it's 0.66 to 1.08 in the Halifax region. It's different in Cape Breton, it's different in Yarmouth. We don't have the exact same ranges across the province. So I'm looking for people to be above 0.9 in that range. But again, it's not perfect. 70%, the stat is 70% of people are low in magnesium. So, and magnesium is perfectly safe. The side effect of magnesium is loose bowel movement. So again, if you have that already, speak with somebody before you take some, but it's also a very safe supplement as well. So unfortunately, the blood work isn't all that accurate when it comes to magnesium.
So this is a question, and I think some of which you've addressed in your presentation, but wondering perhaps if there's something specific to the issue of stroke. So this individual had a stroke 2 years ago and is still often having problems urinating frequently, and wondering what they could do to acquire more control.
Wow. Okay. I would say a stroke is out of my bailiwick. I'm guessing that this has to do with neuromuscular control issues within the brain. And so I'm sorry, but I'm not qualified to answer that question.
Some of what I would think of would be things like B12, magnesium. So after a stroke, the body is doing everything it can to recover. So whatever resources you had in your body already in terms of vitamins and minerals get depleted because your system needs to recover. The other thing that happens as well is that certain times after a stroke, you're put on certain medications, and those medications sometimes will deplete certain things that you need, like B12 or magnesium. But blood pressure medications and statins for cholesterol also deplete your CoQ10, which has a neuromuscular function as well. So again, I can't give specific reasons, but I would think that there's definitely some pieces that are probably just need to be put back together.
Thank you very much. There is a question about accessing the resources. Everybody will be sent a copy of the presentation, and we can include the resources that Sheila and Sarah have provided us with as well. And then I think this one is for you, Sheila. There is someone looking to see where they can get the chair on the last slide.
Okay, so I'm not supposed to promote my
That's
business,
right.
but SheSpot. Yes,
Yes.
we do this in Halifax.
The chair isn't something people buy.
No, oh heavens, no. No, it's something you have to come and get treated. Yes.
And this next question is implied in our title, but someone is wondering about Kegels and if they are helpful.
Yes, so Kegels are one form of pelvic floor physiotherapy. They're certainly the most famous one. There are a lot of misconceptions around Kegels. They're not that easy to do. One of the misconceptions that I'd like to address is that doing a Kegel is the same as stopping your pee flow. First of all, you should never stop your pee flow. I mean, maybe once every few months to test your strength, okay, but don't do it as a matter of course. A lot of people think that that's a great way to, keep their pelvic floor strong, but it actually just confuses your pee system completely. So don't do that. One of the best people to explain how to do a Kegel is a woman called Michelle Kenway, and we'll, if I can remember, we'll put this into the resources that you get sent at the end. So Michelle Kenway is an Aussie who's on YouTube. She does a great job of explaining Kegels, which are more complicated than just holding your pee. So rather than try to do a Michelle Kenway right here.
We appreciate that.
Yeah, we'll leave it to her.
Now we have a question about a drug, and I'm going to see if I'm pronouncing it correctly. Tamsulosin, Tamsulosin. And so they want to know any information you can provide them about that.
So my understanding is that it's a common drug for prostate. I'm not sure. I mean, maybe if the question could be a little bit more specific, I'm not quite sure what to say about it.
So maybe we will ask if anybody wants some information about that. Perhaps they could just resubmit us a question with a little bit more specific request in there. And
That would be
come
great.
back to it.
Absolutely.
All right. Now, interesting question. Is there such a thing as drinking too much water? And is it bad to ignore your bladder when you have the urge to go? So 2 questions there.
Okay, I'll start on this one. So is there such thing as too much water? Yes, it is possible to overhydrate your system. So we're supposed to, every body is different, but we're supposed to drink 6 to 8 cups of water a day. This, of course, depends a great deal on whether you're drinking tea versus water, you know, so are you drinking a diuretic or are you just having plain water, for instance? Are you exercising a great deal? Is it a blisteringly hot day and you're sweating like mad? All of these things influence how much you need to drink, but it is possible to overhydrate your body. And Sarah, I'm sure you've got something to say about that one too. Anything you want to add?
Yeah, absolutely. So when I speak with patients about water or even liquids, so what ends up happening, it depends, like Sheila said about the tea, but it's also coffee, it's alcohol. So what happens is some of those things dehydrate you. And so you need to drink equal and then plus some to really make sure you're hydrated properly. And a lot of people go, I can't drink all that. I'm going to just drink less coffee, or I'm just going to drink less alcohol or less tea or whatever it may be. And so that's fine, absolutely. Definitely, I find when we're talking about bladder, you never want to go, let's say you drink a glass of water a day right now when you take some supplements or some medications because your bladder is that overactive. Well, the last thing you want to do is then start drinking 6 to 8 glasses of water. So it's, again, talking about the bladder retraining, it's a body retraining too. So you never want to go from very little to tons of water. The other thing I will say is that it also depends on your vegetable intake. Vegetables and fruits are full of water. So if you have lots of those, you don't necessarily need to have as much water as somebody who's eating mostly carbs and protein as well.
Now there's 2 more things in the answer and the question. So one of them, if I can remember both of them, one of them has to do with, do you is it good to hold your pee when you have to pee? So, and postpone peeing. That's a kind of a yes and a no answer. So it's never good to hold on with that state of tension, like you're trying to hold the pee inside. It only works if you can break the signal. So when you start in bladder retraining, I'm sure you've all had that situation where you had to pee and then you got distracted by something and then you didn't have to pee again for 5 minutes or an hour even, or 2 hours because you were busy doing something else. So breaking the signal is that you're distracting your brain. So now you don't have that tension. You don't have that sense like, oh my God, I really have to pee. So you're not holding on, you're postponing the void by breaking the signal. And that's a crucial difference between those 2 things. So the other thing that I wanted to talk about was something that Sarah mentioned about not drinking too much as a method of control if you're peeing often. So dehydration as a management technique for incontinence is a really bad idea, because what happens is you end up with concentrated urine inside your bladder. And now, because you've got more parts per million of the bad stuff in there, your bladder becomes more inflamed and more hysterical about making sure it gets rid of it. So that technique backfires, and it's actually much better for your bladder health to keep it well hydrated. A lot of people will dehydrate for the whole afternoon while they're doing chores, and then they'll chug 2 liters of water, which produces a tsunami in the system, and that's not good either. You need to kind of create your own sense of balance, but sipping water, just plain water all day long is if it's possible for you, is absolutely the best way to hydrate and keep that system nicely flushed through without over challenging it either by dehydration or the tsunami.
Thank you. Someone is wondering about a treatment strategy for people with ICS, perhaps the latest treatment strategy or a recommended treatment strategy.
ICS, so like so are we talking interstitial cystitis? Are we talking something different that maybe isn't coming to mind right now?
I'm going to assume that you're correct in your assumption. It's not spelled out in the question, though.
Okay, so I'm going to go based on that in terms of mine, and then Sheila, if you have anything to add, absolutely. So interstitial cystitis is very different for every single person. And I know I kind of sound like a broken record on that, but there are certain supplements that work really well for people and certain ones that don't. So typically if you have IC, you end up having trouble with B vitamins, but are completely fine with B12 if your B12 is low. Typically, magnesium is very helpful. That bladder lining, there's a number of things that can help the bladder lining, and it does depend on the person, what bladder lining support helps them. So that's not something I can get into right now. Again, food is a big thing. I do a lot of food intolerance testing. Potatoes is super common food intolerance for people with IC because of its inflammatory nature. And what happens with potato is that you have the potato, but we have it also. The word enriched means potato in your wheat products. The word vitamin A palmitate or skim milk means potato in your dairy. So it's not just as simple as, oh, I just won't eat potato anymore. And that's another whole thing. But that's where I start, or most naturopathic doctors will start when we're dealing with IC. I don't know, Sheila, if you have anything to add on that.
No, I think that's more your bailiwick.
All right. Someone is wondering what you would recommend as a first step in investigating bladder control issues. So would it be the diary? Would it be the B12, vitamin D, magnesium? Where would they begin, or where's a likely place to start the journey?
Well, it really depends on the nature of the problem. So is it urge? Is it stress? Is there a bit of leakage? Do you pee too often? Are you getting up in the night? Like once you understand your bladder issue in terms of what are the symptoms, then you're in a better position to do something about it. So the bladder diary is certainly a good place to start. Pelvic floor physiotherapy, if you don't mind the intrusiveness of it, can give you good information. And I'm not supposed to promote my business, but we do full assessments as well. So you can also book time with us and talk to us, and we'll give you some insights.
And in terms of the naturopathic side of things, it's really important, no matter if you have bladder urgency or bladder concerns or not, to check your B12, to make sure your vitamin D is good for everything, not just for your bladder. So I would absolutely start there. It's also worth getting a urinalysis done and making sure you have a look at those results, or have someone look at them for you, or ask your doctor, did I have leukocytes? Did I have white blood cells? And then those things can give you a place to start if you'd like to go further with a practitioner.
Thank you. Someone is commenting on the smell of urine, and sometimes it smells very strong ammonia scent. And I guess inheriting that, is that something to be concerned about?
Me, you?
Yeah, I think Sarah, Sarah, why don't you take that one?
Sure.
Because you're more about what's inside.
Sure. You know what? Sometimes yes, sometimes no is the answer. It completely depends. Oftentimes urine smells much stronger if you are dehydrated. So that's definitely something to address if you are smelling a stronger urine. Sometimes it can mean a low-grade infection as well. So if that's happening to you, definitely worth getting checked out. And sometimes that's just your normal urine smell. So again, there are pieces you can kind of look at to figure out if that is normal for you. It may or may not be.
And of course, what you eat changes that too, right? So obviously things like asparagus, but there are other things that we eat that end up coming out in our pee and smelling differently than usual.
There is a question, I think, related to this issue of the smell of urine. And this person is noticing that older women can often smell of urine as if it's more than simply leaking. And they're saying now that they're older, they're also noticing that their urine smells differently, and it is not a pleasant smell. For this particular individual, they are drinking plenty of water. They have had a bladder infection, so they know it's not that kind of aroma, but just wondering, are there changes in the smell of your urine over time? Are there smells perhaps that we should be concerned about, or changes that should serve as a red flag?
Absolutely. So the first thing I'd like to point out is that this low-grade infection that I'm mentioning is very different from a bladder infection that needs to be treated with an antibiotic. So even though it's not the same as that, it doesn't mean that there aren't still white blood cells in the urine. So definitely still worth ruling that piece out. Urine smells can change as hormones change. So as we all know, the vaginal lining gets drier as we enter perimenopause and into menopause. And so hormonal changes also create a different smell. I think in terms of SHELAGH, and you can nod your head or correct me, but sometimes too, like I think part of the question was, sometimes older women will smell of urine, or they feel like they're smelling. Sometimes that is where a little bit of that leakage is happening when you don't really know because you don't feel it as well. But I would think hormones, and definitely not to rule out just that mild white blood cell that could be happening, but there's probably more to the story, and I'm not thinking about it right now.
I have a very specific question. Can Cystoplus ease or lessen the need to urinate continually? This individual's pharmacist noted that the Cystoplus has a lot of salt in it, which deterred them from making the purchase. Is that a...
That is very, I'm not super familiar. I'm just looking it up quickly right now. Sodium citrate, sodium. You know what? I don't think I'm qualified to quickly answer that question right now. I think I will have to pass on that one at this point.
Well, we will move on to one that may be for you, Sheila. If one is using Botox, would Emsella also be helpful? Is it a combination that is complementary or contraindicated?
It would certainly not be contraindicated, and it could potentially be complementary insofar as Botox addresses the spasming of your bladder. So when it's like overzealous about getting rid of stuff. And whereas Emsella is more about the neuromuscular connections and the education and the toning of your pelvic floor. So even though your bladder may be under control, you could still have stress leakage, for instance, in which case Emsella as well as Botox could work very well together. They certainly are not contraindicated. One of the downsides of Botox is it can make it more difficult for your muscle to fully contract, your bladder to contract for long enough, because of course it's trying to get it to not contract so much, to void completely. And so the counterbalancing effect of Emsella could actually be helpful. I've never had a client who's done both, but there is certainly no reason why you couldn't, because they would be potentially complementary.
The next question has to do with a different kind of treatment. This individual has had several DMSO bladder day surgery treatments by their urologist. And is this still considered to be a current treatment? And they have had ICS for 20 years.
Well, there are a lot of different surgical procedures. I'm not a surgeon, so I can hardly address those as to what is the most current. But there are the slings, different forms of slings. There is also procedures where you tie the bladder up. And if you have a prolapse situation, those surgeries can be very effective. Did they last forever? No, they don't, but only a urologist would be able to recommend appropriate surgeries.
And in terms of the specific DMSO, it really, the role of the DMSO is to decrease the inflammation of the bladder. And so if other things have been tried, and so basically for those who don't know, it's inserting a solution in the bladder holds it, and then they release that DMSO solution. It's called an installation. So it's mostly used for interstitial cystitis. My understanding is that it's used at other times as well. However, what I'm finding with patients is that it's not being used as often as it used to be. Medications are often being prescribed more by urologists at this point. However, when a DMSO treatment works for somebody, it can be a very viable treatment for sure.
Excellent. This next question says, 5 minutes after leaving my urologist's office where a scan showed my bladder was empty and normal, I had 3 massive leaks on the way to my car. And they're just wondering, where does this urine come from?
Well, if it's showing your bladder is empty, but presumably if you were doing a flow test, you were asked to drink a great deal of water in order to fill up your bladder and then void it to, this is typically how a flow test is done. And then you void it and they see, okay, did your bladder get rid of everything? But of course, the moment your bladder's gotten rid of everything, it's starting to fill up again, because that's the nature of the process, right? It never stops. And when your bladder voids completely, there's always a little bit left in there. So while it is unusual to have a massive leak when there's only a small amount of pee in there, if your sphincter and your pelvic floor are not up to the task, then it doesn't take very much pee in there to feel as though you're having a massive leak.
I am keeping an eye on time, and we are very quickly approaching our end, with several questions both left in our Q&A and in the chat as well. But perhaps we will end with this one, and for those that we didn't get an opportunity to answer, we will try our very best to get you responses in a different way. But this person is wondering the best way to stop incontinence when sneezing or coughing.
Right. So it depends on how bad it is. Some people leak a little bit and some people leak a lot. So you can, typically, it's because of laxity, the first thing that we were talking about. And so if you do pelvic floor exercises, not just Kegels, but a range of them, then you can sometimes remedy it. And certainly that's what Emsella is very, very good at, because it tones everything up so that it can counterbalance that extra pressure of coughing and sneezing.
Thank you very much. I think we are at the end for today. I would like to thank everyone. I'd like to thank everyone for coming, but I'd like to thank Sheila and Sarah for this very, very helpful presentation. I think that holistic approach that you had talked about helps us to understand what is happening to the body and potentially why, which then leads perhaps to opportunities to manage our bladder issues. Just to let everybody know that you will get a copy of the presentation. Everybody who is registered, they will receive a copy of the presentation. It will also be put online, so you can access it there as well. In my role with SCANS, I would also like to thank Bill Lee and Bob Russell, who seem to be omnipresent, always able to handle tech needs. And when you turn around, there they are taking care of things. So we do appreciate that. As the world of COVID changes and March 21st approaches very quickly, we are obviously looking at a future that may very well include face-to-face presentations. But thank you all for Zooming with us today. This will be our last presentation for the spring. We will be coming back in the fall with the new series of courses with some more public lectures. So on behalf of everyone at SCANS, thank you all, and thank you, Sheila and Sarah.
Thank
Thanks
you.
for
It's been a
having us.
pleasure.
And yeah, thanks for coming, everyone. This was fantastic.
Yes, thank you.